Good morning, ladies and gentlemen, dear friends. It's my great pleasure to welcome you to this ESC 2021 live session entitled Atrial Fibrillation in Heart Failure, Pharmacological or Ablation Therapy. This is an exciting topic and we have two excellent speakers, but we also need you. While ESC 2021 is a digital experience, you still have the option to interact with us. So please send us your questions and comments via the chat box, and we will try to incorporate them into discussion at the end of the session. So without further ado, it is my great pleasure to announce the first presentation, Atrial Fibrillation in Heart Failure, Optimal Pharmacological Management. This will be given by Professor Jens Nielsen from Aarhus, Denmark. Jens, we are looking forward to your talk and the screen is yours.
Thank you very much, dear Chairman, dear everybody. Good morning. It's indeed a great pleasure for me to give this presentation on the optimal pharmacological management of atrial fibrillation in heart failure. Under this heading, I will touch upon the following areas: oral anticoagulation, rate control, rhythm control, what we can call upstream therapy, and also a little about what do we know about the differences between the different types of heart failure, whether ejection fraction is reduced, mild reduced, or preserved. Let's start out with maybe the easiest part, the anticoagulation. And there are good data here shown in a meta-analysis that the novel oral anticoagulants have advantages with respect to risk of stroke or embolism, as well as with respect to risk of death as compared with warfarin. These were not mainly heart failure patients, but in this analysis, you can see how many of the patients were heart failure patients, the subgroups from these large trials. And that was quite many patients. Here you have more than 30,000 heart failure patients from these trials. And this analysis indicated that morbidity and mortality is increased when these two conditions are seen together. And stroke risk is significant with AF in all subtypes of heart failure. The novel or the non-vitamin K antagonist oral anticoagulants are effective and safe in atrial fibrillation and heart failure. However, there are no dedicated studies demonstrating what is the effect of the different anticoagulants in heart failure patients specifically. Okay, rate control in atrial fibrillation. Let's look into this nice paper from 2016. We know that we have to head for something rate control something between 85 and less than 110, because both below that and higher than that, we buy some problems. And in heart failure, especially if you have the higher risk, that may increase the risk of heart failure or deteriorated. Which drugs can you use for rate control? If you have no heart failure or you have preserved ejection fraction, typically you will start out with beta blocker, maybe non-dipyridine calcium channel blocker. And then you can add digoxin, and you can even use all three together. If you have heart failure with reduced ejection fraction, typically you will go with beta blocker. And then if this is not sufficient, you can consider adding digoxin and or amiodarone. Or you can use the combinations. And if this is not enough, you have to leave the pharmacological treatment and do something else. In patients with sinus rhythm, typically you will use beta blocker as first choice, because there are good data showing that beta blocker improves survival in these patients. But as you see on the right panel, this seems not necessarily to be the case in patients with AFib. What about digoxin? The data are very diverse, and there are a lot of observational data, as you see here, indicating that, of course, if you have heart failure, your risk for dying is higher. If you are on digoxin, it also seems to be higher. However, as shown on this paper from the group of Deepak Koteka, there may also be some bias and confounding in many of these studies that are observational. Because if you look at the randomized controlled trials, digoxin seems not to be worse. This not very big, but well done trial from the same group comparing digoxin and bisoprolol as rate control in beta blocker, found no difference in the main endpoint of quality of life after 6 months. What about rhythm control? We all know that this is problematic in patients with heart failure, and you can use amiodarone in all, but we also know that if we could avoid taking amiodarone, we would like to avoid it because it has a lot of side effects. But all the other drugs are problematic, class 1C and also the other class 3. From the guidelines, we have this nice figure. And if you have patients who have preserved ejection fraction heart failure, you can use class 3 antiarrhythmics. You can use so low. Personally, I don't like it. If you have heart failure with reduced ejection fraction, you can use amiodarone. And these are the options you have alternative to catheter ablation. It's not much. With respect to upstream therapy, in my mind, the results have been a little disappointing, but there are data today that the mineraloreceptor antagonists may be or may have some effect. In this analysis, they described, the authors, that the aldosterone pathway blockade have effect on to reduce new onset AF, recurrent AF, and also AF in heart failure. So may have some effect. What about the more recently introduced drugs, the SGLT2 inhibitors? Also here, data seems promising. This slide shows the incidence of atrial fibrillation in cardiovascular and renal outcome trials. And what you can see is that the risk of atrial fibrillation was significantly lower with the SGLT2 inhibitors, 0.79 in the risk ratio. This trial in diabetes patients, also you can see that risk of AFib was lower with dapagliflozin, also in heart failure patients, although the numbers are small. And here also in the heart failure patients, what you can see is that if you look in the patients who have no atrial fibrillation, and in those who have atrial fibrillation, in both groups, empagliflozin seemed to reduce cardiovascular death or heart failure hospitalization, as well as all-cause death. And the effect seemed to not be lower in the AFib group. To summarize, ladies and gentlemen, on optimal pharmacological treatment for AF in heart failure patients. Oral anticoagulation is important, it matters, and most you will treat with DOACs or NOACs. Warfarin when this is not indicated or contraindicated. Rate control, in most cases, you would start with beta blocker. You could use calcium channel blocker, digoxin, and amiodarone. For rhythm control, amiodarone is the only drug that you can use for all. A few you can consider dronedarone or solvo. Mineralocorticoid receptor antagonists may reduce risk of AFib, and SGLT2 inhibitors also may reduce risk of AFib. A few questions not answered. The choice of oral anticoagulant in heart failure patients are based upon subgroup analysis. There are no dedicated RCTs in these different categories of heart failure patients. What is the optimal rate control at HFrEF? have mild reduced ejection fraction, have PEF. Which antiarrhythmics are optimal in those with mildly reduced ejection fraction and preserved ejection fraction? And what is the effect of neuroreceptor antagonists and SGLT2 inhibitors in these three classes? Thank you very much for your attention.
Jens, thank you so much for this great overview on the options, opportunities of pharmacological management of atrial fibrillation in patients with heart failure. I was always impressed by the data from Deepak Kotesha on the role of beta blockers in atrial fibrillation patients with heart failure. And when I saw first the different effects of beta blockade in heart failure patients with sinus rhythm that is absolutely absent when it comes to mortality in atrial fibrillation patients with heart failure, I was always ending up with a why question. Why do you believe is that the case that beta blockers cannot deliver in heart failure patients with reduced ejection fraction in the presence of atrial fibrillation as compared to sinus rhythm? Is it a rate control, neurohumoral effect? What's the key behind that?
Yeah, thank you again. That's an excellent question, and I would have liked to answer that clearly, but I also end up not truly understanding why this is the case, and it may be because the rate blocking effect is lower or sometimes insufficient. It may be because the AFib patients also represent somehow another type of patients, or patients who are more progressed in their heart failure disease and their heart disease. Mm-hmm. And of course, the neurohormonal part also plays a role. And no, I would have liked to come with a more clearer answer, but sorry, I can't.
Yeah, but at the end, it's good that the SGLT2 inhibitors seem to work, and this gives us hope.
And then maybe I would add right there, the SGLT2 inhibitors. You've shown that fascinating potential of those drugs also in AFib patients. Does that affect now the order in which you introduce your heart failure medications, particularly in your atrial fibrillation patients?
Very, very soon we will see new guidelines on the management of heart failure, and I expect that SGLT2 inhibitors may also be introduced here. So I would rather wait 2 days before I answer that.
Thank you so far, Jens. We will come back to the general discussion at the end of this presentation. One more time to our audience, please use the chat function. Please interact with us and enrich this session with your question, your comments. Now we move on to the second presentation of this session, and it's a privilege to introduce Professor Karl-Heinz Koch from Hamburg, Germany, one of the promoters of ablation therapy, catheter ablation in atrial fibrillation. And Karl-Heinz Koch will summarize for us the role of atrial fibrillation, catheter ablation in heart failure, when to consider ablation therapy, and when it may be too late. Karl-Heinz Koch, please.
Thank you very much, Dr. Hendricks, Dr. Reichlin, ladies and gentlemen. I think that the two questions that were addressed to Professor Nielsen indicated already how important it is to maintain the sinus rhythm. So don't spend your time in treating atrial fibrillation. Spend your time to change atrial fibrillation in sinus rhythm. And let's talk how this can be done. That's, I think, the lesson of the last 10 years of working in this field, that we spend more time how to change patients from atrial fibrillation into sinus rhythm. And I think it becomes also very important in the heart failure population. Now, let me just indicate that there is no industry relation with respect to this presentation. And I want to address some strong arguments that I hope we can use here to better identify the subgroup of patients with atrial fibrillation and heart failure And as you would see, I will mainly spend some time on reduced ejection fraction, but we have now also some good data from the Cabana trial on patients with preserved ejection fraction. Now, if it comes to this topic, we know from observation studies of catheter ablation in patients without heart failure. So these are patients with normal ejection fraction, aiming at complete electrical isolation of the pulmonary veins, could demonstrate that this ablation technique was able to restore stable sinus rhythm in the majority of patients, also with persistent forms of atrial fibrillation, unresponsive to electrical cardioversion. So we are not talking about long-standing persistent, but we're talking about short-standing persistent atrial fibrillation, 6 months, 1 year. Now, the superiority of catheter ablation over antiarrhythmic drug therapy in these patients has been confirmed also in randomized trials. And finally, meanwhile, we have 4 randomized controlled trials in heart failure patients that have shown in selected patients that catheter ablation is superior to antiarrhythmic medication as well as to atrioventricular nodal ablation with pacemaker. And I want to make this argument very strong. Who are these patients? That's, I think, the most important question that we need to address. Now, if it comes to the most recent guidelines and you look into first-line therapy recommendations in patients with heart failure, you find 2 indications. There's a strong class 1 indication, of course, in patients in whom we know that atrial fibrillation is causing tachycardia-induced cardiomyopathy. Now, this is sometimes difficult, of course, to understand this direct causal relationship, but of course, there are patients with a high rate, as was addressed by Dr. Jens Nielsen, that most likely, of course, at least have an atrial component to their ventricular dysfunction. And then in addition, as a class 2 indication, should be considered in selective atrial fibrillation patients with heart failure and reduced ejection fraction to improve survival and reduce heart failure hospitalization. Now, we know that this recommendation comes from the CASTLE-AF trial, and therefore I just would like to address the major information that comes from this trial with the primary endpoint of death or hospitalization for worsening of heart failure. And as you can see, that patients in blue undergoing catheter ablation versus patients under optimal medical treatment, that there is a significant benefit that these patients have from catheter ablation with respect to the primary endpoint. And this primary endpoint was not only driven by rehospitalization for heart failure, but also by a reduction in mortality. The effect could be shown around 1 year of follow-up. Now, if you look into what has not been part of the paper, but has been presented in the initial presentation, that of course, as we know from many other treatments in heart failure, the major effect comes by the absolute change in left ventricular ejection fraction. Here you can see data after 12 months, 36 months, and 60 months. And you see the group in red that underwent catheter ablation, in green that underwent medical treatment. And you can see there was a significant increase of the ejection fraction after 12 months by 7%, after 36 months by 4.5%, and after 60 months even at 8%. And it is important to know, to understand this study and why is it so beneficial, that there was almost no effect in optimal medical treatment, almost no effect over time. And this causes the benefit. The benefit was exclusively at the side of patients undergoing catheter ablation, and there was no effect on ejection fraction in patients under optimal medical treatment. And I come back to this in a minute. Now, let's have a look to this very important subgroup analysis of the CASTLE-AF trial. And then you find already at this point in time some important hints. What is the optimal patient population to consider catheter ablation? Now, if you look at this, who did profit from catheter ablation? Now, first, the younger patient population below the age of 65. Second, the patients with not so much advanced heart failure, which was the New York Heart Function Class 2 instead of Function Heart 3 with advanced heart failure. And finally, patients with the somewhat better ejection fraction above 25% as compared to those with a very poor ejection fraction below 25%. And This all is very important to also understand the data of the AMICA trial. The AMICA trial was a European randomized controlled trial, including patients with New York Heart Classification 2 and 3, and therefore an indication for an ICD or a CRT device because the ejection fraction had to be below 35%. And then patients had to be on optical medical treatment. This study, in contrast to CASTLE-AF that also included PAF patients, we only included persistent AF and long-standing persistent AF patients into the trial. Now, if you look into these data, then please remember that in the CASTLE-AF trial, there was no benefit in the class 3 population. And as you can see, the data, of course, of CASTLE-AF were not published when we designed this trial. In the AMICA trial, the majority of patients had advanced heart failure, 60%. Also, as mentioned before, we had only patients with persistent and long-standing persistent AF. And again, don't forget, in the CASTLE-AF trial, there was no benefit for patients below the ejection fraction of 25%. And in our trial, the mean ejection fraction in the ablation group was 27%. It was 24%, almost 25% in patients under optimal medical treatment. So we are looking into a patient population with advanced heart failure and a very low ejection fraction in the AMICA trial. And because of this, we did not see any difference, any benefit from catheter ablation in this population with respect to the primary endpoint, which was an increase of the ejection fraction comparing catheter ablation with drug treatment. But please take into consideration, we also saw in the ablation group an increase of the ejection fraction by almost 9% after 1 year. However, in contrast to CASTLE-AF, we also saw an increase of ejection fraction in the group with best medical treatment. And I will come back to this also in a second. So if we would have treated the patients worse with optimal medical treatment and would not see any benefit in this group, we would also have shown a significant improvement in ejection fraction. And of course, the ejection fraction increase leads to better clinical outcome, as we all know. Now, what is also important to see, this is the ablation group on the left, and this is the best medical treatment group, and this is the atrial fibrillation burden. Now, if you look over time, you can see that patients that underwent catheter ablation, 72% had either no atrial fibrillation after 12 months or a very low atrial fibrillation burden below 5%. These are the green columns. Now, in contrast, in the best medical treatment group, the atrial fibrillation burden at 0% or less 5% was significantly less as compared to the patient population with catheter ablation. So also here we have to confess that catheter ablation was able to maintain sinus rhythm in 3/4 of patients, and this was significantly better than in patients with best medical treatment. But it looks like that at a very late stage of heart failure, patients do not profit anymore from restoration and maintenance of sinus rhythm. So it becomes critical to look into the timing. And let's therefore directly compare CASTLE-AF and AMICA. And here you would see that if we do this, as mentioned before, AMICA had only 40% of patients in both groups with not advanced heart failure at an early stage. Now, in contrary, we had 60% of patients in the advanced state of heart failure, whereas this was only 30% in CASTLE-AF. The baseline ejection fraction in AMICA on average was 27%. It was 32% in CASTLE-AF. And as you can see, this is also true for the control group, 24 versus 31%. Now, as you can see, and I mentioned before, this is the change of ejection fraction after 1 year. It was very much the same in AMICA and CASTLE-AF in the ablation group. However, there was no change in the CASTLE-AF medical treated group at 2% versus 7.8% in the AMICA group. What I also believe is very important, our CASTLE-AF were including patients that could not be treated better with respect to maintenance of sinus rhythm, because at the very beginning, already 60% of the patients in CASTLE-F were pre-treated with amiodarone in both groups. This was significantly less in the AMICA trial. So that explains why over time we had more patients in sinus rhythm than compared to CASTLE-F. If you look into these data, sinus rhythm, you can see that there were significantly more patients, 51% in AMICA at the end of 1 year in the best medical treatment group, and only 25% in CASTLE-F as compared to 62% with catheter ablation. Now, these data were also confirmed with CABANA. You can see that CABANA were looking into 778 patients. This is 35% of the overall patient population that had heart failure. Now, in contrast to the other heart failure trials in catheter ablation, the majority of the CABANA trial had a preserved left ventricular ejection fraction. This were 80% in those patients randomized to ablation, and also 80% randomized to best medical treatment, and only 10% had a reduced ejection fraction in both groups. Now, if you look to the patient population, as you can see here, the majority of patients were in the age range between 65 to 75, and which is also very important, as in CASTLE-F, the majority of patients, 73% and 78%, were in New York Heart Classification 2. So only very little information about patients with advanced heart failure, and the ejection fraction was normal for the overall patient population. And only 7 and 8% had an ejection fraction below 35%. So a completely different patient population with heart failure. Nevertheless, there was a significant benefit in blue shown for the ablation group as compared to the drug group with respect to the primary composite endpoint. And there was also a significant benefit with respect to all-cause mortality, and this difference was highly significant with a reduction of 43% in favor of catheter ablation. Now again, if you look into which patient did profit from catheter ablation, these are patients where we are looking into total mortality that had a complete case. And as you can see, there was no benefit in the patient population with the low ejection fraction, but only patients with an AF above 50%, which was confirmed if you look into a larger patient population with multiple imputations. So this is a post hoc analysis collecting more data on ejection fraction. You can see that this difference became significant in favor of catheter ablation in the CABANA trial. Now, in conclusion, Mr. Chairman, ladies and gentlemen, CASTLE-F trial shows that only selected heart failure patients with low ejection fraction profit from catheter ablation. These are patients below 65, New York Heart Class 2, ejection fraction above 25%. The AMICA trial supports these data. Patients with heart failure, which is advanced and atrial fibrillation, and a significantly reduced AF did not reveal any benefit from catheter ablation. Finally, CABANA, the catheter ablation arm, also showed clinically important improvements and survival improvements and freedom from AF recurrence, mainly in the ejection fraction group above 50%. So I conclude that the effect of catheter ablation of atrial fibrillation in heart failure patients may be affected by the extent of heart failure at baseline, with a rather limited ablation benefit in patients with seriously advanced heart failure and low ejection fraction. And therefore, my strong recommendation is that catheter ablation of AFib should be performed and considered early in heart failure patients when they are still in New York Heart Classification 2 and have an improved ejection fraction, at least with a cutoff rate of above 25%. Thank you very much for your attention.
Thank you very much, Professor Cook. That was an excellent and comprehensive overview of the ablation data in atrial fibrillation in heart failure. Let me start with a question. You nicely pointed out the importance of the selection of the appropriate patients that still have some benefit for improvement. Now there's new, and you showed in AMICA 72% of patients with an AF burden less than 5%, and it's probably hard to be better. With the advent of new ablation technologies such as pulsed field ablation, do you see any potential that this could change and that we could get even better and widen the field of patients that could benefit?
It's not only PFA, which I believe will change the entire field. It's also, as you very well know, the 3 randomized trial using cryoballoon ablation in non-heart failure patient as a primary treatment that show that early catheter ablation before you start any consideration to treat these patients with antiarrhythmic drugs. Early ablation is the step for the future. Early ablation, of course, has to be safe. And therefore, PFA will have a lot of potential, even in contrast to the excellent technology of cryoballoon ablation. But we know that cryoballoon is still associated with some potential complications, which hopefully we will not see with PFA. But nevertheless, I would put a word of caution forward here. I mean, the number of patients that have been treated with PFA is very, very small. So if we take PFA into the real world scenario, I'm 100% concerned. We will see phrenic nerve damage. We will see some collateral damage. And there is no technology in biology where you have 0% complications. So there is a lot of good optimism to share. But, you know, the experience with PFA is very limited in comparison to all the other technologies.
Yes, that was a great overview on catheter ablation procedures in heart failure patients. And we will now open the general discussion and open up the whole field of medical treatment and ablation treatment in heart failure patients. I remind you on using the chat. There are questions coming in the chat. Please use that intensely to communicate to us. And there is a number of questions, and they go to Jens Kosidis Nielsen addressing this is a how-to session. So it's very practical. How do you titrate rate control in your heart failure patient? You mentioned that there are no clear-cut values that we can use for HFrEF, mid-range heart failure. How do you do that practically? What is your preferred drug setup, and how do you titrate? How do you control the titration?
That is an important question, and normally we would do it the way that we in most patients would start with beta blockers, and if tolerated, it should probably be tested by 1 day of Holter monitoring or something like that to ensure that you have a nice control over the rate. That's not too high. That's not too low. So that is what it should be done. If it is not enough, then I would add drugs on that, and in many patients it would be digoxin.
Yeah. When do you go to AV nodal ablation?
Rarely, very rarely. Sometimes in our CRTD patients, when they have undergone ablation several times and still have difficulty controlled AFib, we will do AV nodal ablation. But otherwise, in very elderly patients where we cannot control the rate.
We will see new data on AV nodal ablation coming up during the digital experience, I think today or tomorrow. And
tomorrow evening, 6 o'clock.
It's when, tomorrow or today?
Tomorrow evening, 6 o'clock, I think.
The Brignola data.
Yeah.
Oh, cool. Yeah. Okay, there's more to come. I have to challenge Karl-Heinz Cook with the, I'm completely with you. Catheter ablation in heart failure patients is a key element to improve quality and maybe also quantity of life. But I'm still puzzled with the perspective that we can get from the large trials. I follow the main path that you have paved out for the interpretation of CASL-AF and AMICA. I'm a little bit puzzled with the HFpEF data from CASL-AF, putting that into perspective of the recently still unpublished but presented RAF data, where catheter ablation obviously did not perform so well in HFpEF patients. Any speculation on this, or should we simply wait until it's published?
Yeah, again, I think that we have to wait until it's published. I'm also surprised, of course, about the very good efficacy of catheter ablation in HFpEF patients that have been presented in the Cabana trial. Taken into consideration, I mean, these were the intention to treat analysis, that the intention to treat analysis for the overall trial was not positive. So that is a bit surprising to me too, because we know from patients with hypertrophic cardiomyopathy, which in some way represent the extreme of HFpEF, that the results of catheter ablation are rather poor in this patient population with very stiff left ventricles and very high left atrial pressures. So this is somewhat surprising to me too. It's also surprising that for the other subgroups, as we would expect, we don't see too much of an effect of catheter ablation in the very low ejection fractions. But for the very high ejection fractions, I think these data need to be confirmed. Don't forget, this is a subgroup analysis, and it's not a study that was specifically designed to show a benefit in HFpEF patients. That is exactly what Jens Nielsen was mentioning, that we are lacking specific randomized trials for catheter ablation as well as for drugs in the different types of heart failure. But if I can follow for a second, Jens Nielsen, one of the major limitations that I always see and have been illustrated also from my presentation is that the heart failure patient population in the interventional cardiology trials with optimal medical treatment is not always so well under control, because everybody is looking in these trials to show the benefit of the intervention. We know the differences from the co-op trial. The co-op trial controlled very well the control group under best medical treatment, whereas the French trial, the MITRA-FR trial, did not. So shouldn't we have specific guidelines also how to follow patients with interventional trials for optimal medical treatment? All the trials usually say the control group was under optimal medical treatment. It's not indicated how this was controlled, when this was reassessed. And we know from the co-op how important that is to control the control group. And most of the time, there's a lot of time spent in the intervention group, but no time in the control group. And as you could see from the CASTLE-AF, there was no benefit in the control group, and that made the trial positive. But if you control the control group, you may have also a better result under best medical treatment. Any word on this from your side?
I agree very much that we, and also the question, what is the optimal medical treatment? Yes. And how it is truly ensured that this is followed throughout the trials. So I agree that may be among the reasons why we see the big variation in results that we see. Mm-hmm. Can I maybe with another question? Many of the patients we have today with atrial fibrillation are elderly patients or even older patients 80 years or older, and none of these patients almost were included in the trials. Can I have your thoughts? What do you think? How should we should we do in these patients? Should we also go for early ablation in these patients when they have heart failure and they develop AFib, or are the data also covering these patients?
Well, first of all, I personally believe age is not a disease, and if you are getting older, you will agree with me, at one point in time, that age is not a disease. If you are turning 70, that's rather close to 80. And you still want to be treated from a doctor as somebody who is 50. And I will ask you to do that in my personal case, to be honest with you. So that's my first statement. The second statement, as we are discussing here, don't wait until the patient is in persistent forms of atrial fibrillation. Ablate him early. Don't wait until he's 80. Ablate him when he is 60. So I think we should teach the people that time is crucial in medicine. We should intervene early. We should prevent, but not wait to the very late stage of any kind of disease. So why is the patient ablated at 80? Most of the time, these guys have catheter ablation for 10 years already, and nobody did it. Now, at the end of the life, somebody comes up and says, now you need an ablation. I think this is the wrong thinking. We have to move it forward. And as Tobias was mentioning, if we have safe technologies, and there's some things on the horizon, I think it becomes more easy. We will have more data. We have great data to move everything forward. But I would not say because somebody is 80 he cannot get it plated. I think, you know, you have to look to the patient in total. And as you know, many patients at the age of 80 and have atrial fibrillation have just more than atrial fibrillation, and then it needs to be a balanced decision. But I would not exclude somebody just because he's old.
Maybe there's a question in the chat box that goes into this direction. Philip House is asking, would you recommend an ablation in a young patient, 50 years, with AFib, but without symptoms? You know, we know these patients kind of persistent AF detected kind of by chance during a routine check. Maybe question to you, Jens. Would you start medications first in a young patient, kind of with EastAF-Net data, or would you go straight away to ablation with such a patient?
We may go for cardioversion of a patient and ask him if you don't feel better now, because many of the patients will then. We will, in a young patient, we will discuss with this patient whether or not to continue with ablation, yes.
I think that at this meeting, the EastAF trial will present the data on asymptomatic versus symptomatic patients in the trial. And don't forget, 40% of the patients were asymptomatic. And I know the data, but of course I'm not allowed to share the data with you. But every guy who is interested in that question should listen to this presentation.
There is a question coming up to the treatment strategy for catheter ablation. Quick question to both of you. What is your initial strategy in heart failure patients with persistent atrial fibrillation?
The answer is simple for myself. As in other patients, we start with isolation of the pulmonary veins and then cardiovert the patient and do not more, except that the patient cannot be cardioverted. Then we add linear lesions, cafe ablation, whatever. But this is our primary strategy. And only if the patient comes back, we add more ablation to the left atrium and the right atrium.
Jens?
No, I agree completely. PVI is what to do first.
Mm-hmm. Yeah, that's a clear-cut message. We are in the last minute of this great session. So first of all, I would like to thank the two presenters for a great presentation covering pharmacological therapy for atrial fibrillation and also the emerging role of catheter ablation, maybe even at earlier stages of heart failure with atrial fibrillation than we have done that in the past. We would like to thank the audience for active participation. There are still dozens of questions coming into the chat, so stay active, stay with the ESC digital experience. Enjoy the next 4 exciting days here, transmitted from Amsterdam to the cardiovascular world. Thanks for staying with us. It was a privilege and pleasure having you with us. Enjoy the further course of the ESC digital experience. Thank you so much and bye-bye.
Thank you.
Bye-bye. Thank you.